morning.
Yeah.
Millions of people are going to swing their legs out of bed.
Yeah.
They'll put their feet on the floor, take one single step, and feel what seems like a rusted nail driving directly into the bottom of their foot.
It is brutal. Just the absolute worst way to start a day.
Right. And the crazy thing is, there was no dramatic accident. Like, there was no snap on a football field or some sudden fall on the ice.
No, not at all.
It's just this quiet, agonizing failure of this microscopic tension network that, honestly, they probably didn't even know they were destroying.
It really feels like the ultimate betrayal of the body,
Yeah.
Yeah. Because we are so culturally conditioned to think of injury as this binary event.
Like an on-off switch.
Exactly. You slip on the ice, you fracture your arm, you get an x-ray, and boom, there is a jagged white line that the doctor can literally point to. It's visible, it's clean.
But the stuff we're looking at today is, well, it's the absolute definition of diagnostic muddy waters.
It really is.
And that is exactly our mission for this deep dive. We have this fascinating stack of clinical protocols, functional anatomy guides, and client-centered exercise prescriptions.
Huge amount of material.
Yeah, and we are synthesizing all of this into an owner's manual for your body. So for everyone listening, we are focusing entirely on the wear and tear, the overuse injuries that almost every single one of you will face at some point.
Because it's inevitable if you move.
Right. We're going to look at why they happen mechanically.
Yeah.
And most importantly, how to actually fix them.
And the big shift in perspective here is we have to move away from that acute macro trauma.
The sudden snap.
Right, the snap. We have to focus entirely on microtrauma. These are tiny, repeated, abnormal stresses on your tissues. You don't feel them on step number 1.
Or even step 100.
Exactly. You feel them on step 10,000 when the structural integrity of the tissue just finally reaches a tipping point and fails.
Because it's a compounding effect. I mean, looking at the clinical breakdown here, these microtraumas don't happen in a vacuum. They're caused by this collision of extrinsic and intrinsic factors.
That's a crucial distinction.
So the extrinsic variables are the things you're actively subjecting your body to, like running on non-resilient flooring or training errors.
Like suddenly deciding you're going to double your running mileage this week.
Yes. Or just wearing running shoes way past their functional lifespan. We've all done that.
Oh, absolutely. And then those extrinsic forces, they meet your intrinsic reality.
Meaning your actual body.
Right, the structural alignment you were literally born with, or the muscular adaptations you've developed over, say, 15 years of sitting at a desk.
Right.
So if you have a slight malalignment, let's say your foot hyperpronates, and you combine that with a slight intrinsic muscle imbalance, and then you add the extrinsic factor of a worn-out shoe.
That's the recipe. That multiplication is just chronic breakdown waiting to happen.
It is.
Now, before we really start mapping out this kinetic chain, there is a very strict boundary established in these rehabilitation protocols regarding scope of practice.
Yes, we really need to highlight this.
Because we're looking at this through the lens of exercise professionals, personal trainers, and preventative reconditioning.
Yeah.
But there is a hard line where the gym ends and the clinic begins.
It is a non-negotiable boundary. Exercise specialists are incredibly vital during the final stages of a rehab program, for correcting the biomechanical faults that caused the injury in the first place.
Right.
But they cannot diagnose the root cause of chronic pain. If you're experiencing pain that is severe, if it just completely fails to go away with rest.
Or if it's hot, right?
Yes, if the joint is noticeably hot, inflamed, or if the pain is the direct result of a specific physical accident that is a hard stop, you have to see a physician.
It seems obvious, but I mean, people try to foam roll their way out of structural damage all the time.
Oh, constantly.
If it's hot, swollen, and constant, you don't need a new stretching routine. You need a doctor. So for this deep dive, we're focusing on the preventative strategies and the reconditioning phase once you are actually cleared for movement.
Exactly. And to effectively navigate that reconditioning phase, we have to start by using the correct language, because people throw clinical terms around at the gym constantly without understanding what they actually mean.
I am 100% guilty of this.
Yeah.
I'll say, oh, I sprained my ankle, or I sprained my hamstring.
Most people do.
Let's actually decode the language of tissue breakdown here. The protocols define these very rigidly. Let's start with a ligament sprain. We're talking about the structural connective tissue that holds bone to bone, right?
Right. It provides the static stability of a joint.
So when you suffer an acute trauma, to that specific tissue, it is a sprain.
Yes, ligament sprain.
Yeah.
And the severity dictates the mechanical consequence. So a first-degree sprain is just a partial tear. You retain structural integrity, but you'll experience some minor joint instability.
But a third-degree sprain is the catastrophic failure.
Complete tear. Full joint instability. The structural tie between those two bones is just severed.
Okay, so ligament sprain. Muscles, on the other hand, strain.
Exactly. Muscles and tendons strain.
So a strain is trauma involving the actual tearing of muscle fibers. The text says a first-degree strain is minor. You have localized pain when you contract the muscle, but you don't really lose measurable strength.
Right. It hurts, but it still works.
But second degree, you have a noticeable functional loss of strength because a significant portion of the fibers are actually compromised. And third degree is, again, the complete rupture.
But if we want to talk about the chronic overuse loops that keep people in pain for years and years, the most crucial distinction we need to make isn't actually between a sprain and a strain.
What is it?
It is the fundamental difference between tendinitis and tendinosis.
This was a massive realization for me when going through the sources, because everyone who has a nagging elbow or a sore heel says, oh, my tendinitis is flaring up.
Everyone says that.
But looking at the pathology here, there is a massive line drawn between those two states. Tendinitis is defined strictly as an overuse condition involving active inflammation.
It is the acute phase. The tissue is actively vascularized, it's flooded with blood, and it's responding to a recent stressor.
I always pictured tendinitis like a fire alarm going off inside the joint. It's hot, it's angry, the sirens are blaring.
That's a great way to look at it.
But tendinosis is entirely different. The sources define it as collagen degeneration resulting from a lack of adequate repair of tendinitis.
And this is where the medical management of overuse injuries so frequently derails for people.
Because tendinosis isn't a fire anymore. It sounds more like a frayed rope holding up a suspension bridge. The rope isn't burning, but the structural integrity of the braided fibers is just fundamentally degraded.
Yes.
So if I have tendinosis and I'm popping ibuprofen and icing it, I'm basically spraying a fire extinguisher onto a frayed rope. It's not going to rebuild the bridge.
That is precisely why anti-inflammatory agents are so often ineffective for chronic tendinosis, particularly in areas like the Achilles.
Wow.
The inflammation is largely gone. The cellular reality is degenerative change. You cannot ice your way out of degraded collagen. You have to mechanically rebuild the tissue capacity.
That completely reframes the entire approach to nagging injuries. If you've had that pain for 6 months, you aren't fighting a fresh fire. You are dealing with structural rot.
Exactly.
And speaking of structures under immense tension, let's look at the absolute foundation of human movement. Let's trace these forces starting from ground zero of the kinetic chain.
The foot and ankle complex. It's the site of some of the most stubborn overuse injuries we encounter.
Let's go back to that morning heel pain we talked about at the very beginning, plantar fasciitis.
The dreaded morning step.
The anatomy here is incredible. We're dealing with this strong, multi-layered, fibrous connective tissue. It anchors at the heel bone, the calcaneus, and it runs the length of the sole, dividing into 5 distinct bands that insert onto the toes.
Its mechanical function is essentially a dynamic bowstring.
A bowstring. Okay, explain that.
So as you bear weight, the arches of your foot naturally want to slacken out under the force of gravity. The plantar fascia tenses up to resist that flattening. It absorbs the impact and maintains the structural vault of the foot, working right alongside the intrinsic muscles.
So why is that very first step in the morning the one that feels like a nail in the heel? I mean, if I've been resting it all night in bed, shouldn't it feel better?
You would think so, but the physiology of sleep actually works against you here.
Really? How?
Well, while you are resting, the plantar fascia naturally contracts and shortens. If that tissue is already suffering from microtrauma and chronic inflammation, it tightens up significantly overnight.
So the bowstring shrinks.
It shrinks and all the surrounding tissues become rigid. Then the alarm goes off. You swing your legs out of bed, you stand up, and you instantly drop your entire body weight onto that foot. You are violently, instantaneously stretching a shortened, damaged, and inflamed bowstring. The tensile force at the attachment point on the heel is just immense.
That makes perfect sense of the limp. You see people hobbling to the bathroom, walking on the outside edges of their feet just to avoid putting direct pressure on that heel point.
Exactly. They're instinctively offloading it.
But what is causing the bowstring to fray in the first place? The biomechanical causes listed in the sources are like a perfect storm of extrinsic and intrinsic factors.
Overpronation is a massive contributor here.
Meaning the foot rolls inward too much.
Yes. If the subtalar joint rolls inward excessively during your gait cycle, it forces the midfoot to collapse. And that places an incredible eccentric load on the plantar fascia. But we also have to look at the muscular support system.
All right, the intrinsic muscles of the foot. The protocols specifically highlight weakness in the flexor digitorum and the tibialis posterior.
Those are crucial.
So if those muscles are weak, they can't do their share of the heavy lifting. The fascia is basically left alone to hold up the arch, and the loads are wild. The text says that during a moderate downhill run, the plantar fascia has to withstand a 3 to 5-fold load increase upon landing.
Just think about that. You are asking a passive fibrous band to do the job of active dynamic muscle tissue.
That's going to fail.
It will fail. And the kinetic chain implications are fascinating here because the root cause of plantar fasciitis often isn't even in the foot itself.
Wait, really? Where is it?
The calves, the gastrocnemius and the soleus.
How does a tight calf muscle end up tearing the bottom of my foot?
It's all a matter of restricted biomechanics. If your calf muscles are chronically tight, they restrict dorsiflexion at the ankle joint.
Meaning you can't flex your foot upward toward your shin properly.
Correct. The ankle becomes rigid. Now, during a normal walking stride, the ankle joint is supposed to absorb a massive amount of shock by flexing.
Okay, I follow.
If it cannot flex due to a tight calf, that kinetic energy doesn't just disappear. It has to go somewhere.
So it bypasses the ankle.
Exactly. It bypasses the ankle and is transferred directly down into the foot. The foot is forced to compensate, meaning the plantar fascia has to absorb the impact that the ankle was actually supposed to handle.
So the foot is paying the debt of the stiff ankle. That is wild.
It's the kinetic chain in action.
So what are the clinical interventions here? When the pain is really acute, the protocols suggest a very specific physical therapy technique. Ice massage for 5 to 7 minutes, multiple times a day. But specifically, rolling the sole of the bare foot over a frozen water bottle.
It is highly effective because it acts as a multimodality treatment.
Meaning it does two things at once.
Right. You're getting the cryotherapy from the ice to manage the acute inflammation, but combined with a deep tissue mechanical massage that gently stretches that shortened fascia.
It sounds painful, but amazing. But relief is not rehabilitation, right? If the intrinsic muscles are weak, you have to actually rebuild the arch.
You have to strengthen the foundation.
The reconditioning prescription here involves towel toe curls. Like literally placing a towel on a smooth floor and using your bare toes to scrunch it toward you. Or picking up marbles with your toes.
And here is where we really must address patient compliance and expectations.
Ah, yeah. People get impatient.
Very. These exercises are meticulously rebuilding neuromuscular control and muscular hypertrophy in the foot. The protocols explicitly note that even with daily practice, it may take a full 6 weeks to actually observe a change in the foot's configuration.
6 weeks? You can't just do marble pickups for 3 days and complain to your trainer that you weren't cured.
Exactly. You are attempting to structurally remodel a weight-bearing arch. That takes time. Patience is a biological requirement for tissue remodeling.
Let's move just slightly posterior to the back of the heel. Achilles tendonitis and tendinosis. The pain is typically localized, 2 to 5 centimeters proximal to the calcaneus.
Right above the heel bone.
And the populations most at risk are racket sport players and distance runners.
Because those activities demand relentless, repetitive microtrauma. I mean, think about the explosive push-off required to sprint for a drop shot in tennis.
It's so sudden.
The tensile load on the Achilles during that movement is staggering.
But the protocols point out a very specific extrinsic variable here that I thought was interesting. Non-resilient flooring.
The physics of the surface are paramount. If you are playing on a rigid surface like a hard court that offers zero shock absorption, 100% of the ground reaction force must be absorbed by your biomechanical system.
There's no give.
No give at all. And the Achilles takes the brunt of that impact. Furthermore, healing in this specific zone of the Achilles is notoriously slow because of poor vascularization.
Or lack of blood flow.
Right. Blood flow to the mid-substance of the tendon is inherently limited. That dramatically slows down the delivery of fibroblasts and nutrients that are required for collagen repair.
So the early intervention has to be a drastic reduction in load. The protocol states a minimum 50% decrease in activity volume. Just cut it in half immediately.
At least half.
But there is also a mechanical intervention they suggest, using a 1/4 inch to 1/2 inch heel lift in your shoe.
That is a mechanical offloading strategy.
How does that work?
By elevating the heel bone, you artificially plantar flex the ankle slightly, This puts the Achilles tendon on slack.
Like loosening a tightrope.
Exactly. It reduces the resting tension, which minimizes the micro tearing during just normal daily walking while the tissue attempts to heal.
That's so simple, but so smart. And as we move into the reconditioning phase, to prevent adhesions, which is where the healing tendon basically scars down and sticks to its surrounding sheath,
Right, a
right?
little painful.
To prevent that, the protocol calls for static dorsiflexion stretches. Straight knee to target the superficial gastrocnemius, and bent knee to isolate the deeper soles.
But the real hallmark of late-stage recovery for Achilles tendinosis is eccentric loading.
The four-corner plyometric drill. This really stood out to me in the sources.
It's a fantastic drill.
So you set up markers 3 meters apart in a square. The athlete starts in the center and has to rapidly move forward, backward, and laterally to touch the markers. My question is, why is a multi-directional drill so vital for a tendon that basically just pulls straight up and down?
Because human movement is never perfectly linear. The Achilles must be incredibly resilient against complex, off-axis eccentric contractions.
Eccentric meaning lengthening under tension, right?
Like the braking force when you suddenly stop a sprint. This multi-directional drill forces the lower leg to rapidly decelerate the body's mass from various angles.
So it's teaching it to break in every direction.
Exactly. And that stimulates the tendon to rebuild its tensile strength and actually organize its collagen fibers in a cross-hatched, resilient pattern.
You're basically stress testing the bridge before you open it back up to traffic. It's brilliant.
It really is.
But if the foot and the ankle fail to absorb all of this shock, that kinetic energy doesn't just vanish. It travels north. It moves directly up the kinetic chain into the lower leg. Which brings us to our next segment, the load bearers. The shins and the knees.
And this is where the mechanical consequences of that hyperpronation we talked about really manifest into debilitating pain.
Medial tibial stress syndrome, MTSS.
What everyone just calls shin splints.
Right. The pathology here is inflammation of the fascia, the tendon, the periosteum, the bone, or frankly, all of the above, along the posterior medial border of the tibia.
So the inner edge of the shin bone.
The numbers on this are staggering. The data indicates that MTSS accounts for 10 to 20% of all running injuries, and up to 60% of all overuse injuries in the lower legs for jumpers, court athletes, and aerobics participants.
60%.
It's massive. So what is actually happening mechanically that causes such localized, agonizing pain right on the front of the leg?
It circles back to the gait cycle and hyperpronation again.
Okay, walk me through it.
So, during the mid-stance phase of walking or running, when your full weight is on the foot, the subtalar joint naturally pronates just a little bit to absorb the shock.
Normal movement, right?
But if a client hyperpronates, if the foot rapidly collapses inward, the muscular system has to fire aggressively to stop that collapse and stabilize the foot.
And the muscle pulling the hardest against that collapse is the tibialis posterior.
Exactly. The tibialis posterior is contracting eccentrically. It is trying to shorten to lift the arch back up, but the immense downward force of the body is violently forcing it to lengthen.
It's an extreme physiological tug of war.
Yes. And the loser of that tug of war isn't just the muscle belly, it's the exact spot where that muscle anchors to the shin bone.
The periosteum.
Right, the fibrous outer layer of the tibia. The tibialis posterior pulls so violently and repeatedly that it literally begins to avulse or tear away from the bone. The inflammation isn't just a muscle ache, it is periostitis. And recent clinical evidence suggests that chronic MTSS might actually involve a maladaptive bone remodeling response to this relentless traction.
Meaning the bone itself is reacting.
The bone itself is microfracturing under the stress.
Which completely destroys the no pain, no gain mentality. You cannot power through shin splints. You're literally peeling the tissue off your tibia.
You will only make it worse.
So how do we stop this cycle? The protocols lean heavily on training volume management, specifically something called the 10% rule.
The 10% rule is the golden governor of tissue adaptation. Your weekly workout volume or intensity should never increase by more than 10%.
So if a runner is training for a 10K and they ran 20 miles total last week, they cannot suddenly run 25 miles this week just because they feel highly motivated.
The cardiovascular system might be able to handle it, your lungs feel great, but the structural tissue cannot.
That is the crucial disconnect. The lungs and the heart adapt to stress much faster than the periosteum and tendons.
Returning to activity too quickly or progress in volume too aggressively is the primary reason MTSS just recurs over and over.
While the tissue is healing, The protocols advise non-weight-bearing cross-training, things like swimming, cycling, and when returning to running, terrain selection is critical.
Very.
The recommendation is to seek out grass or flat, bark-covered trails to rebuild mileage before adding intensity.
You are utilizing the earth itself as an extrinsic shock absorber.
It's a great way to frame it.
It artificially decreases the eccentric load required by the tibialis posterior until it is finally strong enough to handle asphalt again.
Now, if we follow the tibia all the way up, we arrive at the knee, patellofemoral syndrome, anterior knee pain.
The classic overuse syndrome of the knee, and it is almost entirely a tracking issue.
The mechanism described here is poor tracking of the patella within the patellofemoral groove of the femur. So if we picture the kneecap like a high-speed train, and the groove in the thigh bone is the track,
I love this analogy.
patellofemoral syndrome happens when the train derails just slightly and starts violently scraping against the lateral walls of the track instead of gliding smoothly down the center.
And the friction from that scraping generates immense irritation, inflammation, and eventual degradation of the cartilage underneath the patella.
But what pulls the train off the track to begin with? The protocols list several structural culprits. Wide hips or knock knees inherently create a larger Q angle, which naturally exerts a lateral outward pull on the kneecap.
Right. That's intrinsic.
But we also see the foot involved again.
The kinetic chain is inescapable. If a client exhibits excessive foot pronation, the arch collapse forces the tibia to rotate internally.
The shin bone actually twists inward.
It twists inward. So now the anchor point for the patellar tendon is rotated. This abnormal tibial rotation drastically increases the lateral tracking force on the patella from below.
So the foot collapses, the shin twists inward, and the kneecap gets dragged into the wall of the femur. And yet people will just put an ice pack on their knee and wonder why it keeps hurting. It's a structural chain reaction.
Ice won't fix a twisted track.
But there is an extrinsic factor here that absolutely blew my mind regarding running shoes. The protocols outline a very strict 500-mile rule.
It is an engineering reality. The ethylene vinyl acetate, or EVA foam, used in most running shoe midsoles, experiences what's called a compression set.
The protocol states that to avoid patellofemoral pain, running shoes must be replaced if they are older than a year, or if they have more than 500 miles on them, which is about 800 kilometers.
Even if the tread looks totally fine.
Yes, even if they look brand new on the bottom, the internal shock absorption is completely dead.
They lose their functional elasticity. And when the shoe stops absorbing the shock, the impact forces are transferred straight up the rigid tibia and directly into the patellofemoral joint.
Which just batters the kneecap.
Exactly. Walking, by comparison, reduces impact forces in the lower extremity by 60% compared to running.
So switching from a run to a walk during the acute phase is a massive biomechanical reprieve for the knee.
Huge.
There is also a very specific warning in the reconditioning protocols about the weight room. To avoid exacerbating patellofemoral pain, clients must strictly avoid deep squats.
It all comes down to joint reaction forces.
The protocols explain that closed kinetic chain exercises like squats, requiring knee flexion greater than 90 degrees, exponentially increase the compression and tissue stress between the patella and the femur.
Think about the physics of it. As you descend into a deep squat, past parallel, the quadriceps are under immense tension. They are pulling the patella tightly against the femur.
Right.
The deeper the angle, the harder the patella is driven into the groove. If that joint is already inflamed from poor tracking, a deep squat is akin to taking a hydraulic press and crushing the train into the tracks.
Ouch. So you just restrict the range of motion, keep the flexion under 90 degrees to maintain muscular activation without joint destruction.
Yes, keep the train safe.
It is fascinating how gravitational force and impact work their way up from the arch of the foot through the tibia and into the kneecap. But overuse is not solely a product of fighting gravity and ground reaction forces.
No, it's not.
It is also deeply connected to the engine room of the body, the massive musculature that propels us forward and holds us upright.
Which leads us straight into the core connection, the hamstrings and the lower back.
Let's examine hamstring strains. The anatomy here really dictates the vulnerability. The hamstring group on the posterior thigh consists of the semimembranosus, the semitendinosus, and the biceps femoris.
But the defining structural characteristic of the hamstrings is that they are biarticular.
Biarticular, meaning they cross and act upon two entirely separate joints.
Right.
They originate all the way up on the ischial tuberosity, the sit bones of the pelvis, and they run all the way down, crossing behind the knee to insert onto the tibia and fibula.
Because they span both joints, they perform two conflicting actions. They extend the hip backward and they flex the knee backward.
And this biarticular design is exactly why they are so notoriously susceptible to high-velocity tears. We see this all the time in sprinters, soccer players, football players.
Yes.
I want to break down the exact mechanism of a sprinter tearing a hamstring because the physics of it are incredibly violent. It usually happens in what is called the terminal swing phase.
Okay, picture the exact millisecond before the sprinter's front foot strikes the ground. The leg is reaching forward at maximum velocity.
At this precise moment, the hamstring is firing concentrically at the hip. It's trying to aggressively shorten to pull the leg backward and propel the body forward.
Right. But simultaneously, at the knee joint, the lower leg is whipping forward,
Oh,
which means the hamstring has to fire eccentrically to hit the brakes and decelerate the tibia before the knee hyperextends.
So it's a profound physiological contradiction. The proximal end of the muscle near the hip is attempting to violently shorten, while the distal end near the knee is being forcibly elongated under maximum load.
It's a biological tug of war happening in a fraction of a second.
And if there is any underlying microtrauma, or if the opposing quadriceps are disproportionately strong and pull too hard, the hamstring loses the tug of war and tears.
Usually right at the common origin on the ischial tuberosity, or right in the middle of the muscle belly.
The grading for these strains ranges from a grade 1 microtear to a grade 3 complete rupture, which the texts say demands crutches and a grueling 3 to 12-week rehabilitation process.
It is not a fast recovery.
To safely rehabilitate and stretch a muscle that crosses two joints, the protocols detail a very specific intervention: the doorway hamstring stretch.
This is a classic clinic move.
So you lie flat on your back on the floor, positioned inside a doorway. One leg extends straight through the door along the floor, while the affected leg is raised vertically and rested against the door frame. You gradually scoot your hips closer to the wall to increase the tension.
It is a highly controlled static stretch.
But my question when reading this was, why go through the theatrical production of lying on the floor in a doorway? Why not just stand up, lock your knees, and touch your toes like we were all taught in middle school gym class?
Because standing toe touches are fundamentally hazardous to the lumbar spine.
Wait, really? Just touching your toes?
Yes. Think about it. When you are standing and attempting to reach your toes, your lower body is locked into a static position. To get your hand to the floor, you must forcefully flex your spine forward.
Okay, I see.
This shifts the primary axis of movement completely away from the hip joint and forces the lower back to bear the entire load, placing dangerous asymmetrical compression on the lumbar discs.
But the doorway stretch eliminates the spine from the equation entirely.
Exactly. By lying flat supine on the floor, the ground enforces a perfectly neutral spine. It physically prevents the pelvis from posteriorly tilting and the lumbar spine from flexing.
So you successfully isolate the tensile stretch directly onto the hamstring while providing absolute structural security for the lower back.
It's just a much smarter way to stretch.
And protecting the lower back is the perfect entry point for the next major issue, because low back pain is a nearly universal human experience. The protocols cite an estimated lifetime prevalence ranging between 60 and 90%.
Almost everyone listening to this will experience it at some point.
The reassuring data point here, however, is that 90% of clients with acute low back pain should see their symptoms resolve within 6 weeks, largely regardless of intervention.
Right, because it is predominantly a soft tissue pathology, a strain of the lumbar erectors, inflammation of the facet joints, or maybe microtrauma to the intervertebral discs.
But the most illuminating section of these protocols is the breakdown of the biomechanical cascade that causes the pain. It completely shatters the idea that back pain originates in the back.
This is the most important thing we can talk about today.
It maps out a domino effect that actually begins at the front of the hips. Let's trace these dominoes exactly as the protocols describe them, because this is wild.
It's a classic, pervasive pattern of muscular imbalance, largely driven by our modern sedentary lifestyle.
Okay, domino 1. Chronically tight hip flexors on the anterior aspect of the body, usually from sitting at a desk for 8 hours a day. Because they are shortened and tight, they constantly pull downward on the front of the pelvis.
Which triggers domino 2, excessive anterior pelvic tilt.
Right.
The pelvis mechanically tips forward, essentially spilling forward like a bowl of water.
Domino 3. Because the spine is attached to the pelvis, this severe anterior tilt forces the lower spine into an exaggerated curve, lumbar lordosis.
The classic swayback posture you see in so many people.
Exactly. Now, the biomechanical leverage is compromised. Domino 4. When the pelvis tilts forward, the posterior attachment points for the hamstrings are physically elevated.
And that puts the hamstrings in a chronically lengthened state. They are stretched tight all the time, which places them at a severe mechanical disadvantage. They become structurally inhibited and weak.
And finally, Domino 5. Because the hamstrings and glutes are inhibited and can no longer effectively stabilize the pelvis, the central nervous system must recruit backup. The body is forced to rely on the spinal extensors, the erector spinae muscles in the low back. They are recruited way too early and fire continuously just to keep the torso upright.
So the muscles of the lower back are in a constant state of ischemic spasm. They are exhausted, overworked, and in agonizing pain.
But the root cause is entirely anterior.
Yes, if you do not release the hip flexors and correct the pelvic tilt, you will never cure the back pain. You're just treating the symptom.
It is brilliant mechanical deduction. We also have to acknowledge the anatomical changes that come with age, because the protocols do address the spine itself.
The intervertebral discs undergo inevitable degenerative changes as we age. The nucleus pulposus, which is the highly hydrated, jelly-like core of the disc, gradually loses its water content and decreases in volume.
The disc essentially dehydrate and flatten out, meaning the bony vertebrae drift closer together.
And concurrently, the annulus fibrosus, the tough, fibrous outer ring of the disc, becomes lax. It loses its tautness.
Like an old rubber band.
Exactly. This combination creates microinstability. The vertebrae have increased play and movement, which causes the body to lay down osteophytes or bone spurs to try and artificially stabilize the joint.
And this increased mechanical stress chronically inflames the synovial facet joints and the surrounding ligaments. So whether the pain is driven by tight hip flexors or degenerative discs, the primary reconditioning prescription is core stability.
But the protocols are very clear on this. We are not talking about doing hundreds of crunches.
My goodness.
They divide the core into distinct functional layers. You cannot train power until you have trained stability.
Right. They define middle layer stabilization exercises. The protocol details the belly blaster exercise. Have you used this?
Oh, it's fantastic.
The client lies supine with knees bent. They actively posteriorly tilt the pelvis to flatten the lumbar spine flush against the mat. Then they raise one knee toward the chest and press their opposite hand forcefully against that knee for 5 seconds, resisting the movement.
To anyone watching, it looks like almost nothing is happening. But internally, it requires intense static co-contraction of the transversus abdominis and the deep multifidus muscles. It is pure pelvic stabilization.
Once that baseline is established, they introduce outer layer power movement exercises, like the dead bug run.
Another great one.
Lying flat, hips and knees at 90 degrees, arms reaching up. While maintaining a perfectly flat lumbar spine, the client extends one leg out while reaching the same side arm overhead, cycling smoothly.
This trains the neuromuscular system to maintain a rigid, neutral spine while the extremities are undergoing dynamic, asymmetrical loads.
It breaks the faulty recruitment patterns of that domino cascade, right?
Exactly. It teaches the brain to fire the deep stabilizers before the superficial movers.
We have traced the mechanical forces from the sole of the foot through the knees and into the lumbar spine. But human overuse injuries are not solely a product of locomotion and gravity.
No, we have to talk about what we do with our arms.
They are profoundly tied to manual manipulation. Let's shift our focus to the upper extremities, the shoulder and the elbow.
And starting with the shoulder, we are looking at arguably the most delicate, easily compromised joint complex in the entire human skeletal system.
Rotator cuff tendonitis, specifically impingement syndrome. The anatomical picture the protocols paint here is incredibly claustrophobic.
It is a notoriously unforgiving corridor.
The space between the head of the humerus, the upper arm bone, and the acromion process, the bony roof of the shoulder blade, is minuscule. We are talking about millimeters of clearance.
And directly through that tiny gap run critical soft tissues. The supraspinatus tendon of the rotator cuff and the subacromial bursa, which is a fluid-filled sac designed to reduce friction.
The mechanics of impingement are fascinating. I'm picturing this space under the acromion. It sounds exactly like threading a thick braided rope through a very narrow metal pipe.
That's a perfect image.
If that rope swells up even a single millimeter, or if the angle of the metal pipe shifts just a degree, the rope gets trapped and violently scraped against the metal every single time it moves.
That is the exact mechanism of impingement. And the protocols break down the kinetic malfunction that causes the pipe to shift. It all revolves around scapulohumeral rhythm and muscular fatigue.
Let's break that down. When you raise your arm overhead, the massive deltoid muscle is the primary mover. But if left to its own devices, the deltoid's line of pull is straight up.
It wants to jam the humeral head directly vertically into the acromion roof. It is a brutal shear force.
So to counter this, the much smaller rotator cuff muscles, particularly the infraspinatus, are designed to act as depressors.
Right, so as the deltoid pulls the arm up, the infraspinatus simultaneously pulls the ball of the humerus down, allowing it to smoothly clear the acromion roof.
It is a highly synchronized mechanical dance.
It is, but if the infraspinatus becomes weak or fatigued from repetitive overhead microtrauma like throwing a baseball or serving in tennis, it fails to depress the humeral head.
The deltoid overpowers the cuff.
Exactly. The humerus migrates superiorly and the supraspinatus tendon gets crushed against the bone.
And there's an intrinsic postural component here as well. The protocols note that major anterior muscles, like the pectoralis major and the latissimus dorsi, act as internal rotators of the shoulder.
And because we spend our lives hunched over keyboards and steering wheels, those anterior muscles become chronically tight and shortened.
They pull the shoulders forward into a kyphotic, rounded posture, while the small external rotators on the posterior side, the infraspinatus and teres minor, become overstretched and functionally weak.
And that forward rounding of the scapula physically depresses the acromion.
Meaning it drastically narrows that already tiny subacromial space.
Which is why attempting to strengthen the shoulder with heavy overhead presses while in an impinged state is catastrophic.
You're just grinding the rope against the pipe over and over. So the intervention must begin with activity modification. The protocols dictate avoiding overhead serving in volleyball or tennis.
If swimming, modifying the stroke to stay within the plane of the scapula.
To maintain cardiovascular conditioning without overhead stress, they recommend cross-country ski machines or rowing. But the core of the physical rehabilitation is entirely focused on scapular stabilization.
This is key. The protocols mandate that clients must reestablish proper kinematic control of the scapula before initiating any isolated rotator cuff or deltoid strengthening.
They detail a specific re-education exercise, wall slides. The client faces a wall, places a folded towel against it, and presses the ulnar border of the wrist, the pinky side, into the towel.
While actively keeping the scapula depressed and protracted, they slowly slide the towel up and down the wall.
This is pure neuromuscular retraining. It heavily recruits the serratus anterior muscle to glue the scapula flesh against the rib cage and upwardly rotate it.
Which physically opens up the subacromial space while the arm elevates. It is reteaching the central nervous system how to elevate the arm without impinging the tendon.
Moving distally down the arm, we reach the final major joint of this deep dive, lateral epicondylitis.
Universally known as tennis elbow.
The elbow is a fascinating anatomical junction. The protocols describe it as the convergence point, where strong, dynamic arm actions generated from the shoulder meet the enduring, static grip strength demanded by the hand.
And that convergence point is exactly where the structural breakdown occurs. Lateral epicondylitis is defined as microtearing and collagen degeneration of the wrist extensor tendons.
Specifically, the extensor carpi radialis brevis, right at its origin point on the lateral epicondyle, the prominent bony bump on the outside of the elbow.
And the nomenclature of tennis elbow is actually a huge disservice because it obscures the true mechanism of injury. It is fundamentally an overuse injury driven by prolonged, repetitive grip strength.
The protocols explicitly list carpentry, painting, gardening, and heavy word processing as primary culprits. The P-cage incidence is between 35 and 50 years old.
It is the cumulative microtrauma of stabilizing the wrist while the fingers are gripping forcefully over decades.
Because every time you tightly grip a hammer or a racket, the wrist extensors must fire isometrically to prevent the wrist from collapsing into flexion.
And that relentless isometric tension transfers directly to the tiny origin footprint on the lateral epicondyle.
And the most brilliant part of these protocols is how they address the physics of prevention, specifically through equipment modification. If a client is a tennis player, the racket itself is the primary extrinsic variable.
The physics of the impact are highly manipulatable.
The protocol states that to reduce the occurrence of injury, players should utilize a larger racket head made of lightweight material, strung at a medium tension, paired with a larger diameter grip handle.
It all matters.
But why does the size of the handle and the tension of the strings matter so much to the elbow?
It is all about vibration dampening and mechanical torque. A larger racket head with softer medium tension strings expands the sweet spot and absorbs significantly more of the kinetic energy of the ball.
So less vibration travels down the shaft into the arm.
Exactly. Furthermore, a larger diameter handle increases the moment arm for the gripping muscles. The hand does not have to contract as forcefully to prevent the racket from twisting upon impact.
which drastically reduces the eccentric shock delivered to the extensor tendon origin. It is pure mechanical offloading.
They also highlight the use of counterforce bracing, a very common but highly effective intervention.
Wearing a rigid strap tightly around the forearm just below the elbow. The protocol explains that this brace physically offsets the angular acceleration of the muscle force.
By creating a new anchor point for the muscle belly, it literally disperses the tensile force before it can reach the inflamed epicondyle.
You are artificially changing the origin points of the muscle to shield the damaged tissue.
It's a biohack, basically.
It is incredible how much of this rehabilitation relies simply on clever physics, load management, and just respecting the biological limits of human tissue.
It really is.
Which brings us to our final synthesis, stepping back and looking at the entirety of these functional anatomy protocols.
We are looking at a highly integrated, continuous kinetic chain.
From the plantar fascia acting as a tightly wound bowstring under your foot to the violent split-second tug-of-war in the biarticular hamstrings to the millimeter-tight tolerances of the subacromial space in the shoulder.
It's all connected.
These sources make it abundantly clear that our bodies are not just collections of isolated independent parts. They are a single, interconnected tension network.
A dysfunction in one quadrant inevitably forces a compensation in another. A rigid ankle forces the plantar fascia to absorb the impact. A shortened hip flexor wrenches the pelvis and causes lumbar disc degeneration.
A weak serratus anterior drops the acromion roof and severs a shoulder tendon.
It is an inescapable cascade of cause and effect.
And that is the ultimate empowering takeaway for you listening. The stiffness you feel getting out of bed, the nagging ache in your knee after a run, the elbow pain after a day of yard work, they are not just random bad luck. They are not simply the inevitable curse of getting older. They were highly specific mechanical puzzles. They are physical equations with logical, structural solutions.
If you can understand and identify the microtraumas, you can intercept the macro breakdown.
But it demands patience and structural respect. It takes 6 weeks to rebuild the configuration of a foot arch. It requires strict adherence to the 10% rule for training volume.
Tissue remodeling cannot be rushed.
And that leads to a final provocative thought to leave you with. Throughout these clinical guidelines, we see incredibly rigid rules for managing the physical equipment we use.
The 500-mile shoe rule, for instance.
Exactly. The protocols demand that we throw away running shoes every 500 miles because the EVA foam loses its elastic properties. We meticulously track the mileage on our cars to change the oil before the engine seizes.
We track the mileage on our shoes to protect our knees.
But consider this. What if we began tracking the cumulative mileage and daily mechanical stress we subject our own individual muscles and tendons to?
That's an interesting way to look at it.
The X-ray machine will never show you the frayed collagen of tendinosis until the tendon completely snaps. It won't reveal the muddy waters of microtrauma until the structural bridge actually collapses.
It's invisible damage.
But if you learn to read the early mechanical warning signs, the slightly restricted dorsiflexion, the morning heel pain, the subtle forward roll of the shoulders, and if you treated your own biomechanics with the exact same scheduled maintenance, calibration, and respect as a high-performance machine, how much further could you go before the engine light finally comes on?